Thank you for joining my project, Perioperative Amiodarone in Coronary Artery Bypass Grafting. My committee members include Dr. Harris, Dr. Snell, and Don Gosnell. A little background on my project. New onset postoperative atrial fibrillation is a persistent and detrimental complication for patients after coronary artery bypass grafting, or CABG. New onset postoperative AFib not only causes anxiety and discomfort, it also is associated with delays in physical therapy and longer hospital length of stay. Researchers found that prophylactic amiodarone administration can decrease the incidence of atrial fibrillation after cardiac surgery. So the purpose of this scholarly project was to determine whether perioperative amiodarone decreases the incidence of new onset post-op AFib in patients undergoing a CABG. The scholarly project aims to decrease the incidence of post-op AFib and reduce the average length of hospital stay for patients who receive the prophylactic amiodarone. Therefore, the question that guided this project is, does perioperative IV amiodarone reduce the incidence of new onset atrial fibrillation in patients after coronary artery bypass graft surgery compared to patients who do not receive the IV amiodarone? So, little literature review regarding the project. Postoperative AFib remains the most common complication after cardiac surgery, with the incidence varying from 10 to 65%. Postoperative AFib may be short-lived, but it can also persist 6 to 8 weeks after surgery. The incidence of post-op AFib is dependent on the type of operation, patient characteristics, and the definition of postoperative AFib. However, the incidence of post-op AFib has gradually increased due to the aging population and the increasing number of cardiac surgeries being performed on the aging population. That's why effective prophylactic measures are necessary to prevent postoperative AFib, and it improves care of patients undergoing open heart cardiac surgeries. A reduction of post-op AFib was found in patients who received oral or IV amiodarone, monotherapy of amiodarone, and a concurrent use of a preoperative beta blocker and amiodarone. Atrial fib is associated with an increased risk of thromboembolic complications, hemodynamic derangement, worsening of heart failure, and possible stroke. These complications lead to longer stays in the intensive care unit and prolonged total hospitalization. The length of hospitalization for patients who did not receive postoperative AFib average around 6 days, compared to 8 days in patients who did not develop post-op AFib. Two other studies even recorded longer lengths of hospital stay in patients who developed AFib, from 10 to 11 days. This scholarly project was best represented by the Ottawa Model of Research by Graham and Logan. This model has 3 phases: assess, monitor, and evaluate. The first phase calls for assessment of the practice environment, assessment of the potential adopters, and evidence-based innovation. The practice environment of this project was a cardiothoracic intensive care unit at a Midwestern hospital, and it consisted of the appropriate staff and patients for the amiodarone protocol. This facility has a strong focus on quality improvement initiatives and adopts change very quickly and easily. The potential adopters had the knowledge and skill set and motivation for change implementation. 2 of the 4 surgeons adopted the change, while the other 2 did not, but created a control group of patients who did not receive the amiodarone protocol. Assessment of evidence-based innovation involves facilitating perceptions and attitudes of the change by the potential adopters. The adopters in this project believe that change could possibly benefit their patients in their care, and it would not be too time-consuming or difficult to implement. The second phase is monitor. This phase focuses on monitoring the implementation. The staff monitored implementation and provided feedback to the providers and the researcher. Audits include assessment of the understanding of the protocol and ensuring that it was implemented on the appropriate patients. The last phase is evaluate. The last phase evaluates the outcomes. The goal of this scholarly project was to determine the effectiveness of the prophylactic amiodarone in reducing the incidence of AFib. During this evaluation phase, data was collected and analyzed to establish the effectiveness of the protocol. This scholarly project was a quantitative study using retrospective chart reviews. Again, 2 of the 4 practicing cardiothoracic surgeons at the hospital implemented the amiodarone protocol, creating an intervention and control group. The control group received normal preoperative care, which was a beta blocker within 24 hours of the surgery unless it was contraindicated for things like bradycardia or allergy. The intervention group involved a normal preoperative care of that beta blocker and the amiodarone protocol, either intra-op or immediately post-op. The researcher received a list of the medical record numbers of the patients who received a CABG procedure from the manager of the CTICU. I then reviewed the medical record and determined if the patient met inclusion and exclusion criteria and determined whether the patient developed new onset postoperative AFib or not. The sample of this project, the population consisted of patients receiving a CABG procedure in the cardiac thoracic intensive care unit at a Midwestern hospital where I am employed. So the participants were conveniently available to me. Male and female patients between the ages of 18 and 89 years old who underwent a coronary artery bypass graft surgery were the participants of this study. Patients with a history of atrial fib or any other arrhythmia who had a contraindication of bradycardia, had an extra cardiac device such as an Impella or an intra-aortic balloon pump, or had a valvular surgery or a CABG with a valve surgery were all excluded from the study. The sample population produced 202 patients, 156 patients in the control care group, and 46 patients of usual care plus the amiodarone protocol. The demographics of the sample consisted of 75.2% male patients and 24.7% female patients. The age groups of the sample varied. 9.4% of patients were less than 50 years old. 24.7% of patients were in their 50s from 50 to 59 years old. 35.6% of patients were aged 60 to 69 years old. And 30.2% of patients were 70 years old or older. The number of bypasses performed ranged from 1 to 7 bypasses. A CABG times 3 was the most common at 35.6%, followed by a CABG times 4 at 34.6%. There's just 1% difference. So data analysis, I used a z-test for the difference of 2 proportions to determine the statistical significance of the amiodarone protocol. Nominal data was gathered using yes for those who received the protocol and no for those who did not receive the protocol. The achieved power of the study was 0.3922, which is considered low to medium in strength. The difference in proportion of those who received the amiodarone protocol and those who did not was between negative 0.2318 and 0.283 with a 95% confidence. Since 0 was included in this interval, there was not significant evidence to show a change in one direction. The p-value of 0.0814 suggests that there was not sufficient information to suggest a decrease in the ratio from those who not receiving the protocol and those receiving the protocol. The statistical test of hospital length of stay was an independent samples t-test if assumptions were met. The Kolmogorov-Smirnov test was used to determine whether the assumptions were met and if the data was normal. The data was not normal, so a Mann-Whitney U test was used. Ordinal data was collected to determine if the protocol reduced the hospital length of stay after surgery. However, there was no evidence with a p-value of 0.785 in the hospital length of stay. Therefore, there was not sufficient information to suggest a decrease in ratio from those not receiving the protocol to those receiving the protocol. There was not enough evidence to conclude that there was a difference in hospital length of stay between those who received the protocol and those who did not. The total charts evaluated for this project were 262. Of these charts, 41 were excluded due to the patient's history of AFib and the presence of a cardiac device such as an Impella or intra-aortic balloon pump. One patient was excluded because they were transferred to a higher level of care. One was excluded because they left against medical advice before they were discharged. And 4 patients were excluded because they had expired. The mean of participants who received the amiodarone protocol and did not develop atrial fib was 82.6%. The mean of patients who received just the normal preoperative control care group and did not develop AFib was 72.4%. Most patients in both groups did not develop AFib, but a larger percentage of patients in the amiodarone group did not develop AFib. The figure on the chart here, and the figure gives a visual representation of the difference in development of AFib between the two groups. However, this was not statistically significant. Therefore, I can conclude that there was not enough evidence to suggest preoperative IV amiodarone will decrease the incidence of AFib in patients undergoing coronary artery bypass grafting. There was also insufficient evidence to determine that prophylactic amiodarone can decrease the hospital length of stay. Several limitations were identified for this project. First, this study was limited by its retrospective nature. Human errors may have led to incomplete documentation of a history of atrial fib or electrocardiogram documentation of postoperative AFib. Secondly, the chart review was completed just by one nurse, me, which limits the knowledge of the electronic medical record. The study had a moderately large sample size of 202, but the sample size of the amiodarone group was relatively small at 42. Although amiodarone is relatively safe and well tolerated, the medication, like all medications, does come with potential side effects. This study is limited as it did not consider the development of unwanted side effects. Therefore, side effects should be considered before routine prophylactic amiodarone prescription. Generalizability is limited as the study was conducted at only one Midwestern hospital. The homogeneity of the sample may also affect the study's generalizability. The sample consisted of 75% male patients and only 25% female. However, this may be due to the fact that just more men need CABG surgeries compared to women. The relationship between the development of postoperative AFib and the patient's comorbidities and age and other things like that were not taken into consideration, but this may also affect the study's generalizabilities. This practice improvement project identified 202 patients between March 2020 and March 2022. The only preventative measure in place before the implementation of this project was a preoperative beta blocker. The addition of amiodarone offered a low-risk option to help minimize the risk of new-onset postoperative AFib and possibly decrease the hospital length of stay. Although there was a lower percentage of patients who developed postoperative AFib in the amiodarone group, this data just wasn't significant. The data indicated that prophylactic amiodarone did not significantly reduce the incidence of new onset post-op AFib in CABG patients when compared to those who did not receive the medication. There was also no evidence that the amiodarone protocol decreases the hospital length of stay. Therefore, it can be stated that pharmaceutical prophylaxis with IV amiodarone isn't an appropriate way to combat this persistent complication. Amiodarone should be used, however, as a treatment for postoperative AFib after its manifestation rather than introduced prior to this CABG. The results of this DNP project indicate a need for further research in the prevention of post-op AFib. The goal of this study was to decrease the incidence of post-op AFib in CABG patients and hopefully decrease hospital length of stay. Only 17.4% of patients who received amiodarone prophylactically develop AFib, and 27.6% of patients in the control group develop AFib. The hospital length of stay remained unaffected by the amiodarone protocol, and while this project did not have statistical significance, this data is consistent with other studies that did have statistical significance. The data attained was limited as the sample size of the intervention group was only 42. A longer implementation period and a greater number of participants may have produced more statistically significant results. Atrial fibrillation after a CABG surgery is an important perioperative complication that deserves targeted prevention. Postoperative AFib has continued to cause complications for patients after surgery. Patients will forever need cardiac surgeries. It's never going away. And postoperative AFib may always threaten to compromise the patient's recovery. Although risk factors have been identified, the precise cause and mechanism of postoperative AFib still is unknown. Opportunities exist for further research to pinpoint the exact reason and to address the knowledge gaps for the prevention of post-op AFib. Amiodarone is widely used for clinical purposes. However, the routine use of the drug as a prophylactic agent is still controversial. This study did not show a significant reduction in post-op AFib with amiodarone. Therefore, the amiodarone protocol will not continue at the project's facility. Although the study did not yield the expected results, the knowledge and data from this project has influenced current practice. Identifying successful and ineffective measures to reduce postoperative AFib in CABG patients will help influence practice and future research. This study evaluated the effectiveness of preoperative beta blocker administration and perioperative IV amiodarone in reducing the incidence of post-op AFib. To date, there are no concrete clinical guidelines or policies to guide prophylactic treatment of post-op AFib with a combination of beta blockade and amiodarone in CABG patients. So opportunities exist for further research to address the knowledge gaps in reducing post-op AFib after cardiac procedures. Prior research studies have shown a significant reduction of new onset post-op AFib with the use of perioperative amiodarone in patients receiving CABG surgeries. Studies have shown amiodarone to be an appropriate adjunct therapy to post-op care of cardiac patients. In this practice improvement project, there was a lower percentage of patients who developed postoperative AFib in the amiodarone group. However, this data just wasn't statistically significant. Therefore, IV amiodarone does not statistically reduce the incidence of new onset post-op AFib in patients receiving CABG surgeries. Despite preventative measures, atrial fib remains one of the most common complications after open heart surgeries. There is a great need for advancement in preventing post-op AFib in patients after CABG surgery. This project just reinforces the controversial use of amiodarone prophylactically. More research is needed and necessary to evaluate the risk-benefit ratio of amiodarone, the confounding variables that contributed to post-op AFib, and the correct route and dosage of prophylactic amiodarone. The results of this study opened the door for the implementation of different prophylactic agents or strategies to try and tackle this persistent complication. This study still has significant clinical implications because it just adds to the generations of research that are required to improve the translation of evidence into practice, clinical practice. This DNP program has challenged me beyond belief. It has helped me grow as a scholar and a person. These last 3 years have been crazy for a multitude of reasons, but I'm just very thankful for all I have learned throughout this project and this whole process. So, thank you, and thank you for listening to my presentation that I have worked so very hard on. Do you have any questions? And here are my references. Thank you and have a good day.